Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing kidney stones, a common and often painful condition. We'll talk about why people get kidney stones, what you can do to prevent them, and how they're treated. My guest is my colleague, Dr. Jared Winoker. Dr. Winoker is the Director of Endourology and the Kidney Stone Center at Lenox Hill Hospital and an Assistant Professor of Urology at the Zucker School of Medicine at Hofstra Northwell. Jared, welcome to Well Said.
Thanks so much for having me, Ira.
So let's start at the beginning. What is a kidney stone?
Quite aptly named, a kidney stone is just a pebble-like concretion that forms up in the kidney within the urine, and they are typically made of some of the compounds and minerals that are normally excreted by our kidney, and typically they exist within the urine, dissolved, and for whatever reason, and some of the factors and reasons we'll get into, they can actually precipitate or come out of solution into the solid form of a stone.
So this is like a mineral crystallization that happens somewhere in the urinary tract.
Exactly. For those who are not very familiar with the anatomy of the kidney, it has this outer solid component that does a lot of the functional work we think of with a kidney, like cleaning the blood. The center is actually hollow, and urine is constantly being made there and dripping down into the bladder, and this is exactly where the stones will form.
I mentioned in my brief intro that kidney stones are common. So how common are they?
They are quite common, actually. I think our most recent numbers quoted somewhere around 1 in 10 people, actually, in the United States will develop a kidney stone in their lifetime, which may sound pretty surprising for many, and that's because many people who harbor stones don't actually know it. Of course, patients will present with a passing of a kidney stone, which we know is an extremely painful event. However, imaging studies performed for other reasons, it's not infrequent that we will incidentally detect the kidney stone up in the kidney.
So is it fair to say then that a lot more people have kidney stones or get kidney stones than actually present with any kind of symptoms associated with them?
Yeah, I think that's a fair estimate. Of course, that's kind of the inherent issue in really estimating the true prevalence of it, because it's only really reported on pain. So I'm sure there's plenty of people walking around who are not being accounted for that are actually harboring some stones up there.
Let's talk a little bit more about the makeup of kidney stones, because there's more than one type, right?
Correct. There's, of course, innumerable types of stones. Most stones fall into one of 5 types of stones. The most common, probably about 2/3 of stones, are called calcium oxalate stones. Calcium oxalate are common minerals and compounds found in the body, in the diet, and then therefore in the urine. So it's very common to see those, but we'll also see stones made of calcium phosphate, uric acid, a compound called struvite, which is associated with certain types of infection, and then sometimes we'll hear about cystine stones. And there are, of course, other rare entities that occur from different types of medications that are probably beyond the scope of this talk, but they do exist.
So what determines who gets what type?
It's certainly a loaded question. It's a complex thing to answer. In general, it's the metabolic derangements or abnormalities in the urine that are ultimately going to drive what type of stone someone will form. And it's the various factors that I'm sure we'll dive into shortly that kind of drive those different derangements. So just to give you an example, a patient who may have a chronically low urinary pH, that is their acid base level is too acidic, that may favor the development of a uric acid stone. Or if they have excessively high levels of urinary calcium, well, that's going to favor the formation of a calcium-based stone, all things being equal.
Interesting. So let's get into that a little bit about the factors that contribute to the formation of kidney stones. Are there things that are common across all of these different kinds of stones, or is everything a different story?
There is a mixed bag depending on what you have. We do know that certain medical conditions and medications can predispose to stones. Obesity, diabetes, things that kind of fall under this constellation of the metabolic syndromes do contribute to multiple stone types. Certainly, people who have, lower hydration status tend to be dehydrated, high insensible losses from sweating. Those are patients that are going to be at increased risk for forming stones.
Before we go on to talk about other things that contribute to stone formation, you mentioned people who tend towards dehydration are more at risk. I guess that stands to reason, right? It just means that the urine is more concentrated and it's more likely that this stuff is going to kind of form crystals as opposed to stay dissolved in the urine. Is that the basic issue there?
Exactly. And it is why it is such a backbone of some of the dietary recommendations we do eventually give, is that all things being equal, regardless of stone type, we do know that the better hydrated you are, that is making more urine, things are more likely to stay in solution and not come out in the form of stones.
So for people who are not being evaluated for or have been treated for kidney stones, I mean, it's very common to see people walking around these days with water bottles. You see all of this advice in various health promotion kind of publications and advertisements that we should be drinking a certain number of glasses of water a day. Do you ascribe to that? Like, how much water should somebody, a normal person, be drinking in a day?
If we want to go by the book, our organizational guidelines say, well, you should be drinking enough fluid to make 2.5 to 3 liters of urine a day. But you find me someone who's actually out there measuring their urine volume daily, and I think we're dealing with bigger issues than just kidney stones. So what I often tell patients is that you want to be drinking enough fluid, specifically water, that your urine is always going to be crystal clear or very, very faint yellow. So, certainly for different patients or different times of the year, if it's hotter or based on your physical activity level, whether it's from exercise or just your occupation, the fluid status of your body will change, and it's not necessarily what goes in, it's what comes out. So ultimately, you want to be looking at that urine level or that urine color rather, as your barometer that you are drinking enough. And if it's starting to look a little bit yellow, you need to be drinking more.
All right, so that's a pretty good rule of thumb. I like that. So dehydration, or the opposite of getting enough fluid, you said, is a risk factor. Is it understood why some of those other things that you mentioned, diabetes or obesity, is it understood why those are predisposing factors for kidney stones?
I can say it's somewhat understood, the pathophysiologic mechanisms of why certain disease states or conditions will contribute, without getting a little too lost in the weeds. Something like obesity and type 2 diabetes, which are associated with high levels of insulin and insensitivity to insulin in the body. We know that this can cause changes on the level of the cells within the kidney, that they will cause an inability to regulate pH, and at the same time, they can cause a reduction in the level of certain common inhibitors that exist in the urine, most notably citrate. So when you start to have this unbalance of various factors, it can push you in the direction of one type of stone versus another.
That's interesting. What about genetic factors? Kidney stones, do they run in families?
Yeah, absolutely. Like most conditions, unfortunately, we know that genetics are at play, and there's still much more that we don't know versus what we do know. But certainly there is a heritable nature. I would say that, depending on the study you want to quote, anywhere from 30 to 60% of patients who have a kidney stone will have a family history. And there have been some very large genome studies that have identified an abundance of different genes that are associated with forming kidney stones. And they tend to work in a collective, or as we sometimes say in medicine, a polygenic manner to describe this observation of heritability. But that being said, there definitely are a few important genes we do know exist that when a mutation exists in one or several of them, it will lead to a specific disease state that can contribute to kidney stones as one of the potential effects of that disease.
Yeah, if we're talking about ways to prevent kidney stones, other than staying hydrated, and I guess getting those other diseases that we mentioned, like diabetes, under control, is there anything else that people should be paying attention to that kind of lowers or might raise the risk of having a kidney stone?
Absolutely. It's what's fortunate about and I'll call these the generalized recommendations. We can certainly talk about some more tailored recommendations based on further metabolic evaluation. But for any patient, I always give them the spiel of the generalized things, which are increasing your fluid outtake based on, keeping an eye on the urine color, as I mentioned. We want to lower the salt in the diet. We know that excess salt in the diet will make its way into the urine. And interestingly, calcium will follow salt into the urine. And we know that a lot of stones are calcium-based, so that will contribute to higher calcium levels when you have high salt in your diet. Also, moderating or limiting animal protein. These are basic things that we know help to slow the growth of existing stones and prevent the recurrence of new stones. And I'm sure these recommendations sound familiar, if not obvious to many people, because what's fortunate is that they align very much with those recommendations we give for overall health wellness and also for controlling modifiable factors in other disease states like your diabetes and elevated blood pressure.
Yeah, no, I was going to say it aligns pretty well with preventing heart disease, right? If you're lowering blood pressure, limiting salt, limiting your intake of animal protein and tending towards more plant-based diet, that's interesting.
Absolutely.
So let's talk about the part of kidney stones that's a lot less interesting and more unpleasant, which is the pain associated with passing a kidney stone. So I guess we should start by explaining what we mean when we say somebody passed a stone. What does that actually mean?
Well, I'm actually so glad you worded your question that way, because I think there is a large misunderstanding of what passing a kidney stone is. Just if we take a quick step back and just look at what the anatomy of the urinary tract is, it's essentially all plumbing. And as I mentioned, that urine, just like a faucet always being on, that urine is always being made by the kidney, draining out of the kidney, goes down a small little tube that we call the ureter, which runs alongside the spine on either side with each kidney. And then that plugs into the bladder, where it's consistently being drained and stored until it's, of course, socially convenient to go to the bathroom. So when we talk about pain associated with a kidney stone, it's specifically from the obstruction of that constant flow of urine that causes backup of pressure and that debilitating pain that people can have. The way the anatomy is actually shaped is that the kidney and the bladder, these are fairly big open spaces. It's the ureter itself that is orders of magnitude smaller than anything else. And this is where we talk about kidney stone pain. So really anything that's blocking the flow of the kidney from where it takes off into funnel down into the ureter, along the course of the ureter until it plugs into the bladder. So when you pass the kidney stone, it is through the ureter and it is down in the bladder. Whether or not you've peed it out, that's of not importance because you shouldn't really notice it after that point.
Okay, so it's the ureter that's the sort of problem here. Why is that so painful?
That's a good question. A lot of this has to do with the innervation of a lot of our internal organs, which, as I'll often explain to my patients, they don't really feel pain the way some of the your skin and your muscle feel it. What organs often feel is distension or stretching and backup of pressure, and that's a signal that something is not working right. So if this stone, albeit it's very small, so we're talking 4, 5, 6 millimeters, a very small thing, but it's going through a tube that's not much bigger, that's going to back up. It causes stretching of structures upstream, so we're talking about stretching of the kidney and the capsule around it, and that is highly innervated with a lot of nerves that feel pain.
So just an unfortunate intersection of anatomy and physiology there. I don't know what else to say.
Interesting to someone who treats stones, not as interesting to someone who unfortunately suffers from them.
Yeah. So is it the case that most of these things take care of themselves, meaning you have a painful episode, you drink some more water or you get some intravenous fluid, it flushes it out, and that's all that you wrote?
Unfortunately, it's not always that simple. There are definitely a good proportion of patients who will successfully pass a stone without intervention, and that's always our goal, if possible. Given a clinical situation, if a patient is, safe and physically well and we can control their pain because it's often intermittent, we will give them a fair trial of passage for anywhere from, 4 to 6 weeks. But the likelihood of passage diminishes as the size of the stone increases, and also with how high up it is when we find it. So it's often a conversation you need to have with the patient, understanding, what is your ultimate likelihood of passing the stone? Do we want to give it an attempt at passage, or do we want to kind of be proactive and just go up and take care of it up front?
And just to be clear, if you wait a period of time, you're not suggesting that somebody's in excruciating pain for weeks.
Yeah, of course not. No. So, some kind of debilitating pain, bouncing back to the office or an emergency room, God forbid, these are reasons where we consider that a failure of passage.
Okay.
So, we're not trying to have people be tortured, but we do know that there is an intermittency of the pain, and for some patients with appropriate pain control, they can actually pass them and prefer to, as opposed to be, undergoing an intervention.
Yeah, so let's talk about some of those interventions. So if the stone doesn't pass, meaning it got stuck someplace between the kidney and the bladder, what can you do about that?
We're fortunate that there is a range of all minimally invasive options to address it. Most frequently when we're talking about a stone that's in the ureter, by far the most common procedure we are performing is called a ureteroscopy, which is a type of endoscopic procedure, meaning it's, there's no incisions, it's going through your natural orifices. So we're doing this endoscopic procedure under general anesthesia to go up through the urethra into the bladder and then up the ureter in the direction of the kidney until we encounter that stone that's kind of blocking the road. And then we have a special medical laser that we're able to carefully break or fragment that stone and extract the pieces to unobstruct the flow.
Wow. And how effective is that?
For a stone in the ureter, success rate, I would say, is on the order of 85 to 90%, which is very high. And by success rate, the measure I'm using is complete clearance of the stone. Reasons it would not be successful generally would be an excessively large stone that may need multiple procedures to ultimately clear. There can be a fair amount of inflammation in the ureter, not surprisingly, that may impair our ability to safely remove it all in one session. And sometimes patients' anatomies just don't even allow for even the smallest of instruments that we have. And in those cases, we have techniques where we can insert a small tube alongside the stone in the ureter that helps to drain the urine, thereby relieving the pain. And also, over the couple of weeks that it's in, it'll passively stretch out the ureter enough that we can come back at a later date when the inflammation has come down and we can safely remove the stone.
Is it ever the case that you actually have to sort of open somebody up and have a larger scale surgical procedure to remove these things, or are they pretty much all done endoscopically now?
They are all done, to a degree endoscopically. However, the bounds of what's endoscopic, can be stretched. So I would say that the days of opening someone to remove a stone, cutting for stone, as they would say, those are largely gone. We have, other treatment options that exist in the case where, we encounter a situation with larger stones. For example, one of the procedures I perform is a procedure where we go into the kidney percutaneously, meaning through the skin, directly through the back where the kidney is located. And we're able to get into the kidney with the combination of X-ray and ultrasound guidance in a sort of radiologic procedure. And then once in the kidney, we're able to go ahead and break up and extract the stone. And because that tract that we're making through the back is a bigger, path than the ureter, we can use larger instruments and therefore remove things. So it's still technically endoscopic and still minimally invasive, but of course less invasive by nature. And then in rare cases, I'll just for completeness, in rare cases we will still do a laparoscopic or a robotic assisted surgery, but generally that's for extremely select cases, often where something else needs to be accomplished on the kidney surgically at the same time.
I suspect that many of our listeners are familiar with lithotripsy. Do you want to just mention what that is?
When you say lithotripsy, I'm sure you're probably referring to, or our listeners are thinking of shockwave lithotripsy. And the reason I just specify the terminology is that lithotripsy as a term really just means breaking of stone. So shockwave lithotripsy, which is what it's often associated with, is probably the least invasive form of procedure we do for a stone, where under general anesthesia, sometimes moderate sedation, we focus ultrasound waves from outside the body directly at the stone, and the combination of those waves focused at the stone is able to kind of pulverize and break the stone into very tiny fragments, and then we rely on the natural flow of urine to help the body expel those much, much smaller fragments that theoretically should pass without any issue. We also use the term lithotripsy when we talk about a ureteroscopy because we're using a laser to perform lithotripsy. So, if you visit a physician who uses that term lithotripsy, you just want to be sure you know exactly what they're speaking about.
Oh, that's very helpful. Once you get the stone out or a patient naturally passes it, how important is it to actually study the stone itself to figure out what it's made of? Does that have implications for how patients are treated after the acute episode?
It's not really a clear-cut answer depending on who you ask. In my opinion, it's something that's definitely helpful, but it's definitely not necessary. Because we do know a lot about what's going on inside a patient based on the appearance of the stone and perhaps the results of some urinary testing we can talk about. But it definitely can help us to better tailor a treatment. But again, it is not necessary if it's not possible for whatever reason.
So what is the most appropriate sort of evaluation? Somebody is referred to you, they may have been in the emergency room, they passed the stone, they feel fine now. So what do you do to figure out next steps?
The basis of any good evaluation, as you know well, of course, is a thorough medical history taking. We can learn a lot about why someone's forming stones and try to identify those modifiable risk factors just on a good history. But then if we're looking to dive a little bit further, there is some basic testing, a couple of small blood tests that we can perform. And then really the cornerstone of our metabolic evaluation is a special urine test that's called a 24-hour urine analysis. The patient is asked to collect their urine over a 24-hour period, and then we send that specimen to a special lab that is able to calculate the concentrations of various different constituents in their urine over that 24-hour period. So some of the things we were looking at before with the pH, the calcium, oxalate, magnesium, sodium, all these various factors that we know in different concentrations can either promote stone formation or inhibit stone formation. We can understand better what's going on in a typical day in the life of that patient. And if there are some derangements that are noted, we can address these with any combination of dietary modifications, lifestyle modifications, and then not infrequently prescription of medications or supplements.
Anything new or coming on the horizon for kidney stone formers or sufferers?
From a patient perspective, there isn't a new modality, I guess to say, that's readily on the horizon. Though urology as a surgical field, especially for kidney stone disease, is very much steeped in a rich history of surgical innovation, and it's fairly continuous that we're seeing advancements in our instruments, whether it's our medical lasers, the miniaturization and ability to visualize things within the urinary tract, which ultimately just foretells our ability to more safely and more adequately treat patients in a more minimally invasive manner.
Okay. So if any of our listeners were interested in learning more about some of the things we talked about, whether they're dietary modifications or these kinds of advances that you're talking about, where would you direct them to get that information?
There's a ton of great resources. Of course, I do want to give special mention to our Northwell site. We have some great educators and who put together a lot of good content. Though, outside of the institution, one of my favorite resources is the Urology Care Foundation, which can be found through an easy online search. They have a ton of great information, not only on dietary recommendations and, maybe a little bit more of the nitty-gritty of why one forms a certain type of stone, but there are things like recipes and cookbooks for kidney stone formers, as well as a breakdown with some great visuals of some of these surgical procedures if they're planning to have them.
All right. Well, that sounds great. Well, look, thanks so much for sharing your insights with us today.
No, it's my pleasure. I appreciate you having me.
So my guest has been Dr. Jared Winoker. He's the Director of Endourology and the Kidney Stone Center at Lenox Hill Hospital and an assistant professor of urology at the Zucker School of Medicine at Hofstra Northwell. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.